Local anesthesia. Definition. Local anesthesia is drug-induced reversible local blockade of nerve conduction in a specific part of the body that does not alter consciousness. Local anesthetics is classified into two groups: amide group and ester group. Amide group consists of 5 drugs, and the drugs are: 1. Lidocaine, 2. Mepivacaine, 3. Bupivacaine, 4. Atticaine, 5. Prolicaine. Whereas ester group consists of 4 drugs: 1. Cocaine, 2. Procaine, 3. Chloroprocaine, 4. Tetracaine. This chart explains about the maximum dose allowable for the administration of local anesthetic drugs and their duration of action with and without epinephrine. Mepivacaine of amide group should be avoided in pregnancy, and bupivacaine should be avoided in pregnancy until term. The duration of action. The duration of action of the drug is also related to the length of the intermediate chain joining the aromatic and amide groups. Protein binding. Procaine is only 6% protein bound and has very short duration of action, whereas bupivacaine is 95% protein bound and have longer duration of action. Uses of local anesthetic drugs. 1. Local anesthesia. 2. Ventricular arrhythmia. 3. Treatment of epileptic fits. 4. Decrease hemodynamic response to tracheal intubation and also decreases cough. Adverse effects of local anesthetics. The adverse effects on central nervous system are: excitation followed by depression, drowsiness to unconsciousness and death due to respiratory depression. The adverse effects on cardiovascular system are: bradycardia, heart block, hypotension. And the allergic reactions are: allergic dermatitis to anaphylaxis, rare but occurs most often by ester-type drugs. Advantage of using adrenaline with local anesthetics. 1. Epinephrine constricts arteries. 2. Delays the reabsorption of lidocaine. 3. Increases the duration of action of anesthesia. Note: bupivacaine has caused several deaths when the epidural anesthetic has been administered intravenously accidentally. Placement sites of local anesthetics. 1. Surface/topical anesthesia. 2. Local infiltration. 3. Peripheral nerve blocks. 4. Beer's block, intravenous regional anesthesia. 5. Epidural anesthesia. 6. Spinal anesthesia. Contraindications of local anesthetics. 1. Serious adverse drug reaction to lidocaine or amide local anesthetics. 2. Heart block, 2nd or 3rd degree, without pacemaker. 3. Severe sinoatrial block, without pacemaker. 4. Prior to the use of amiodarone hydrochloride. 5. Concurrent treatment with quinidine, flecainide, disopyramide, procainamide, Class 1 antiarrhythmic agents. surface and topical anesthesia. For the application to mucous membranes, nose, mouth, esophagus, tracheobronchial tree, genitourinary tract. Commonly used drugs: cocaine, 4% to 10%. More than 50% of rhinolaryngologic cases in USA. It has unique pharmacological property: it produces local vasoconstriction as well as anesthesia. Localized vasoconstriction. Less bleeding. Improved surgical visualization. Skin surface application. Barrier, keratinized skin layer. Higher anesthetic concentrations required. 5% lidocaine, xylocaine, prolicaine, cetanist, cream. 2.5% lidocaine, xylocaine and 2.5% prolicaine. No local irritation. No systemic toxicity. Even absorption. Local infiltration. Definition: extravascular placement of local anesthetics in the region to be anesthetized. Example: subcutaneous local anesthetic injection in support of intravascular cannula placement. Preferred local anesthetics for local infiltration. 1. Most common, lidocaine, xylocaine. 2. Other choices, 0.25% ropivacaine, Neuropen, or bupivacaine mercaine, effective for the pain management at inguinal operative location. Duration of action. 1. Duration extended by 2 times using 1:200,000 epinephrine. 2. Caution: epinephrine containing local anesthetic solution should not be injected intracutaneously, intradermal, or into tissues supplies by the end arteries such as ears, nose, fingers, because vasoconstriction may be sufficiently severe to produce tissue ischemia and gangrene. Median nerve block. The median nerve is blocked by inserting the needle between the tendons of the palmaris longus and flexor carpi radialis. The needle is inserted until it pierces the deep fossa. 3 to 5 milliliters of local anesthetic is injected, although the piercing of the deep fossa has been described to result in a fascial click. It is more reliable to simply insert the needle until it contacts the bone. The needle is then withdrawn 2 to 3 millimeters and the local anesthetic is injected. Peripheral nerve blocks. Procedure: local anesthetic injection into tissues around individual nerves or brachial plexus. Mechanism: local anesthetic diffusion path, nerve odor surface, mantle, to the nerve core, driving force, concentration gradient. Anesthetize first, mantle fibers innervating more proximal structures. Anesthetized last, core fibers, innervating more distal anatomy. Explanation of why anesthesia develops proximately first. Recovery in the opposite direction, sensation returns proximally first. And lastly, the distal anatomy. Intravenous regional anesthesia, Beer's block. Procedure: local anesthetic injection into an extremity isolated by tourniquet. Result: rapid anesthesia, onset, skeletal muscle relaxation. Duration of anesthetic action depends on how long the tourniquet is kept inflated. Following tourniquet deflation, rapid recovery as blood dilutes local anesthetic concentration. Probable mechanism: drug action on nerve endings and nerve trunks. Epidural anesthesia. Spinal anesthesia consists of different layers. 1. Skin. 2. Subcutaneous tissue. 3. Supraspinous ligament. 4. Intraspinous ligament. 5. Ligamentum flavum. 6. Dura and arachnoid matter. 7. Cauda equina. Epidural anesthesia is given in epidural space. Onset of action. 15 to 30 minutes delay. Choice of local anesthetics. Lidocaine xylocaine, frequently used, diffuses well for tissues. Bupivacaine marcaine, and ropivacaine rupin, 0.5% to 0.74%. Spinal anesthesia introduction. Spinal anesthesia, also called spinal analgesia or subarachnoid block, SAB, is a form of regional anesthesia involving injection of local anesthetic drug into L3-L4 subarachnoid space, generally through a fine spinal needle. Differences include: 1. The involved space is larger for an epidural and consequently the injected dose is larger, being about 10 to 20 milliliters in epidural anesthesia compared to 1.5 to 3.5 milliliters in a spinal. 2. In an epidural, an indwelling catheter may be placed that avails for additional injections later, while spinal is almost always a one-shot only. 3. The onset of analgesia is approximately 15 to 30 minutes in an epidural, while it is approximately 5 minutes in spinal anesthesia. This table explains about the site of injections, onset and duration, advantages, needle dose, space, quality of sensory and motor nerve blocks, and toxicity of epidural and spinal anesthesia. Thank you for watching. If you like this video presentation, please subscribe to this channel for more video updates regarding surgery and anesthesia.